Welcome to the 2021 prize ceremony of the Boris Mintz Institute for Global Challenges at Tel Aviv University. And a special welcome to this year's BMI Prize Laureate, Dr. John Nkinga, Director of the Africa Centers for Disease Control and Prevention, also known as the Africa CDC, for his outstanding role in leading the battle against COVID-19 in Africa. But first, it is my honor to call on Tel Aviv University President, Professor Ariel Porat, to give his opening remarks.
Thank you very much, Steve. Dr. Boris Mintz, BMI founder and president, and Tel Aviv University governor and honorary fellow, and his wife, Mrs. Marina Mintz, Professor Itai Senet, Dean of the Gordon Faculty of Social Sciences, Professor Sylvia Cotton, chair of the BMI Prize Evaluation Committee and head of Tel Aviv University's Herzig Institute on Aging, prize recipient Dr. John Nkinga, colleagues and students, dear participants from around the world. The Boris Mintz Institute, BMI, was founded in 2015 to find strategic, innovative, and feasible solutions that enhance the welfare of communities around the globe. Their important work is carried out in 6 interdisciplinary research labs, ranging from inequality and conflict resolution to sustainable development and demography. The Institute has recruited research teams from across the Tel Aviv University and also collaborates with a wide network of international partners. Now, what impresses me the most about BMI founder, Dr. Boris Mintz, is his pioneering and far-sighted approach to academic research. Boris, a mathematician by training, has his feet firmly planted on the ground. While he encourages and supports highly original research, each project is carefully selected for its real-world value and its potential to have a significant impact on the largest possible group. Excuse me. In just a few short years, the Mintz Institute's reach has spread across the campus, Israel, and the world, supporting dozens of cutting-edge research projects, holding numerous international symposia and webinars, hosting visiting scholars, awarding graduate fellowships, sending PhD students teams to developing countries for fieldwork, and more. The BMI is an exemplary institute at Tel Aviv University in its scope and impact. Since 2017, the BMI has awarded a 100,000 annual prize to an exceptional researcher who has devoted his or her academic life to the solution of strategic global challenge and whose research, public activity, and ideas have had a transformative impact on policy formation and public well-being. Previous laureates have been leading figures from the world's best universities, spotlighting the BMI's international prestige. And now, it is my pleasure to award the 2021 BMI Prize to Dr. John Nkinga, Director of the Africa Center for Disease Control and Prevention, or for short, the Africa CDC. The prize is being awarded to Dr. Nkinga for his management of the pandemic, his public action focused on practical and applicable solutions, and his impact on global policy. At the outbreak of the COVID-19 pandemic, he convened an emergency meeting for all 55 ministers of health of the African Union to discuss and adopt a joint continental strategy, stressing the need to cooperate, collaborate, coordinate, and communicate for an effective response to COVID-19 across the continent. He led the African Union and the Africa CDC to launch the partnership to accelerate COVID-19 testing, which has dramatically increased testing to more than 90 million kids, 90 million kids. And he also orchestrated a major genomics initiative with international partners to survey which variants are circulating in Africa. He is similarly extremely active in the efforts to accelerate access to vaccines. He also holds a long-term vision for a new public health order for Africa, which he laid out at the founding of Africa CDC. I'm convinced that the efforts and commitment of Dr. Nkenga Song have substantially helped to save many lives in Africa during the pandemic and assist in international efforts to control it. We at Tel Aviv University feel the utmost respect and gratitude for his health leadership in the battle against COVID-19 and congratulate him and the Boris Mintz Institute for this prize recognition. Thank you.
Thank you, Professor Porat, for officially awarding the prize. And now, for the presentation of the prize laureate, we call on Professor Sylvia Cotton, Chair of the Prize Evaluation Committee, Head of the Healthseg Institute on Aging at Tel Aviv University, Head of the PhD program in the Department of Nursing at the School of Health Professions at the Sackler Faculty of Medicine. Professor Cotton.
Thank you, Steve. It was my pleasure and honor to serve as chair of the evaluation committee for the 2021 BMI Prize, and I thank the Boris Mintz Institute for this opportunity. I also wish to thank my colleagues at the evaluation committee, Professor Samina Alkai, the 2020 BMI Prize laureate, Director of the Oxford Poverty and Human Development Initiative at the University of Oxford, England, and Professor Joseph Koresh, George Comstock Professor of Epidemiology, Biostatistics and Medicine at the Johns Hopkins University, for their professional evaluation of the distinguished candidates to win the prize. We chose Dr. John Kengason, Director of the Africa CDC, as recipient of the 2021 BMI Prize for his substantial efforts in the management of the COVID-19 pandemic, his public action focused on practical solutions, and his impact on global policy. Dr. Kengason stood out in fighting the COVID-19 pandemic, combining his solid academic background and his outstanding management skills. Dr. Kengason has published over 250 peer-reviewed articles. He has received many international awards and recognitions for his work on HIV and COVID-19. In May this year, he was ranked number 4 by the Fortune magazine as one of the 50 greatest world leaders. And last month, he was named one of the 100 most influential individuals for 2020 in the category of innovator. Early after the first cases of COVID-19 were reported, Dr. Kengason published 2 important articles, a paper in Nature Medicine warning that Africa needed to be prepared to combat the virus, and a paper in The Lancet outlining the strategy Africa needed to adopt to fight the pandemic. He organized an emergency meeting of all 55 ministers of health of the African Union to discuss and adopt an all-continental strategy, which emphasized the need for the continent to cooperate, collaborate, coordinate, and communicate for an effective response to COVID-19 across Africa. He led the African Union and the Africa CDC to launch a partnership to accelerate the COVID-19 testing, and he leads the efforts to speed out the access to vaccines in Africa. Dr. Kengason holds a long-term vision for a new public health order for Africa, which focuses on 4 core areas: maintaining strong public health institutions, locally producing vaccines and medications to ensure health security, having well-trained public health professionals, and fostering an all-of-society approach. We unanimously chose Dr. Kengason for all these reasons and for his leadership and commitment that have substantially helped to save lives in Africa during the COVID-19 pandemic. His work certainly assists in the international efforts to control the pandemic and will influence the management of many other diseases, helping to save lives in the future as well. So thank you, Dr. Kengeson, for all you have done, for everything you are currently doing, and for what you will be continue doing to save lives. And congratulations on behalf of the 2021 BMI Evaluation Committee. Thank you.
Thank you, Professor Cotton. And we are now honored to call on BMI founder and president, Dr. Boris Mintz. Dr. Mintz.
I'm sorry. Good afternoon, ladies and gentlemen. It is my pleasure to welcome you to the 5th annual BMI Prize ceremony. Today, like last year, we are doing the ceremony online. However, I do believe that the next time we will be able to meet in person. I would like to thank Professor Itai Senat, head of BMI, and the Institute's incredible team for putting together this event. Furthermore, I want to extend my gratitude to the 2021 Prize Committee members, Professor Sylvia Cotton, Professor Joseph Koresh, and Professor Sabina Alkaya, BMI 2020 Prize Laureate, as well as all those who have submitted the application for the award. With that in mind, I would like to congratulate the 2021 BMI Prize Laureate, Dr. John Klingelson, Director of the Africa Center for Disease Control and Prevention. The prize is awarded to Dr. Klingelson for his substantial efforts in the management of the pandemic. His public action focused on practical and applicable solutions to these huge challenges, as well as his impact on global policy. Dr. Klingelson's academic research focused on HIV and its characteristic in the Africa, as well as COVID-19 in Africa. He has published over 250 received articles and received many international awards and recognition for his outstanding work. At the outbreak of the COVID-19 pandemic, Dr. Klingelson had convened an emergency meeting of all 55 ministers of health of the African Union to discuss and adopt a joint continental strategy for COVID-19 outbreak. He also led the organization to establish the Africa Genomics Initiative and partnership with the World Health Organization Regional Office for Africa. He established a network for SARS-CoV-2 genomic supervision to learn which variants circulate in Africa. He is extremely active in the efforts to accelerate access to vaccines around the continent. I am convinced that Dr. Klingelson's leadership and commitment have substantially helped to save many lives in Africa during the COVID-19 pandemic and assist in international efforts to control the pandemic. I would like to express my gratitude to Dr. Knigansson for his invaluable achievements and congratulate him on extending the line of outstanding academics who have received the BMI prize. Thank you very much.
Thank you, Dr. Mintz. And now greetings from Professor Itai Senet, the Dean of the Gershon H. Gordon Faculty of Social Sciences and the head of BMI.
Thank you very much. At that stage, I think I will just briefly mention our utmost gratitude to Dr. Knigansson for accepting the prize and becoming part of our family. Please be advised that you will have to come and visit us here, and we will bring you to our family of world leaders who try to make of this world a better world. It's an amazing meeting between Dr. Boris Mintz and Dr. Knigansson, coming from such different backgrounds and meeting here, pursuing exactly the same goal of trying to make this world a better world to live in. It is the norm and the tradition of the BMI organization and institute to make sure that with every new winner, we create a world of collaboration. As the president of Tel Aviv University mentioned, the Boris Mintz Institute has been very active in Africa ever since its inception. But for me, and for us here at the Boris Mintz Institute, this is a great opportunity to do a whole lot more and a whole lot better. So we are honored and overwhelmed with joy for having you the winner of the 2021 Boris Mintz Institute, and we will now be happy to hear your address. Thank you so much.
Thank you, Professor Porat, and we do call on now the prize laureate, Dr. John N. Knigansson, to give his acceptance speech and keynote lecture. The 2021 BMI Prize Laureate, Dr. Knigansson, Director of CDC Africa. Over to you, sir.
Thank you. Thank you so much for the honor and the greetings from Addis Ababa and greetings from the Africa Centers for Disease Control and Prevention, which is a specialized technical institution of the African Union. Professor Laureate Porat, the president of the University of Tel Aviv, Dr. Boris Mintz, Professor Sylvia Cotton, the chair of the committee, Professor Itai Senet, ladies and gentlemen, greetings again from Addis Ababa. It is my honor and joy to accept the Boris Mintz Institute Prize for 2021 from the Tel Aviv University. On behalf of the Africa Centers for Disease Control and Prevention, I express my sincere gratitude and very humbled to have been chosen this year to be the prize winner. It is truly an honor for all of us. For me, representing the Africa Centers for Disease Control and Prevention, which is just barely 5 years old since its creation. I would like to dedicate this prize to the very active staff of the Africa Centers for Disease Control and Prevention that have demonstrated their resilience and the ability to stay on and fight the pandemic. Not just this pandemic, for the other epidemics that we have fought since I became the director of this center. I would also like to dedicate this prize to my family, starting with my wife, Susan, who is on this call, for her relentless support and love over the past 30 years we have been together and accompanied me in this journey in my search for solutions in public health across the continent. Our 3 children are on this platform, Pete, Paul, and Gladys. Thank you sincerely, all of you, for your support. Without that home support, it's always difficult to go out and fight these pandemics. I would like to dedicate this prize, ladies and gentlemen, to the vulnerable populations of the southwest and northwest regions of Cameroon, who have been witnessing an unprecedented crisis for the past 5 years, so that it can contribute in my own modest way to solving some of the health challenges that they face. Ladies and gentlemen, this is an unprecedented crisis. That is, the COVID pandemic crisis in Africa is unprecedented and unpredictable in terms of the trajectory that the continent faces. I would suggest and argue that this crisis is the biggest challenge the continent has faced since independence, since most countries faced independence. In the next couple of minutes, I would like to do 3 things. I will review for you the epidemiological situation of COVID-19 in Africa, discuss some of the early challenges that we faced in making available the testing, which is a cornerstone for fighting any infectious disease, and then also review for you where we are with respect to access to vaccines, and then leave you with some takeaway thoughts. So first of all, let's start with the situation, the epidemiology. I always like to start with this graph, ladies and gentlemen, or this picture, because it shows you 3 things. It shows you how connected we are as a people on the same planet. It also shows the vulnerability that we are faced with as humanity, and also the inequities that exist within countries, between countries, and between regions. As of January 20th, if you look at the top left-hand panel of this graph, only 4 countries had identified the COVID-19 virus, mainly around China and those neighboring countries. About 15th of February, just less than 1 month, 28 countries had reported the virus. And as of March the 1st, about 66 countries have reported the virus. If you look at the map of Africa, it was still very gray, and only about 4 countries or 5 countries have reported the virus. But 20 days later, 165 countries in the world have reported the virus. It shows you again how connected we are, how vulnerable we are, regardless of which part of the world we are. We saw the pandemic evolving, as we have seen in the previous map, and on the 22nd of February, we convened an emergency meeting of all ministers of health in Addis Ababa, the headquarters of the African Union Commission. And the picture you see here is the photo showing all the ministers of health who came in. If you recall, the first cases of COVID-19 were reported on the continent on the 14th of February in Egypt. So just 1 week later, we convened this meeting, which became a historic meeting. At the end of this meeting, we agreed on the need to have a joint continental strategy. At that time, we were calling it an outbreak, to fight the outbreak, which was underpinned by 4 C's: the need to coordinate, cooperate, collaborate, and communicate. That has since remained a guiding principle and underpinning for our ability to fight this pandemic on the continent. Where are we with the situation? As of yesterday, 16th of October, 8.4 million cases of COVID-19 have been officially reported on the continent. And I use the word officially deliberately because our own data and statistics based on serologic analysis from multiple countries suggest that the 8.4 million cases might actually be an underestimate. Of that number, about 215,000 deaths have occurred with a case fatality ratio of 2.5. If you look at this graph on your right-hand side carefully, it shows you 3 different peaks. The first peak of this pandemic occurred around between July and August of last year. And the red line you see there is what we call the 7 days moving average. And the different colors below the thick red line are the 5 geographic regions of Africa. That is Central, East, North, Southern, and Western Africa. Around January of this year, we also saw the second peak, where as a continent, we were reporting about 32,000 cases of COVID-19 a day. And very recently, between July and August of this year, the continent was witnessing a very brutal third wave. And if you look at the width of that third wave, it lasted more than the other waves and with consequences. Let me just focus a little bit on the third wave because it has very significant implications for the conversation we shall be having. If you zoom into that third wave, we span between the 1st of June and October, 3.5 million new cases were reported. If you recall, we currently have about 8.5 million cases, but 3.5 million new cases occurred just within the last 3 months on the continent. We recorded 84,000 deaths during that same period, that is during the third wave. And that represented 42% of all cases and 39% of all deaths since the pandemic started on the continent. This speaks to the brutality of this wave when they come in and go away on the continent. If we now look at the 5 geographic regions, what we are experiencing now is uniformity in the decrease of the number of cases as of between the period of 15 September and 16 of August. The left-hand side shows the decrease in Southern African countries, thanks due to the joint efforts we are working with member states and the individual lockdowns that countries are implementing. West Africa, you see the same pattern, very similar pattern in Northern Africa, as well as in Central Africa, and in East Africa similarly. So overall, the continent is going down, is what we call is flattening the curve of the third wave in a remarkable fashion. However, there are countries that are now experiencing the fourth wave. For example, Kenya. The Kenya situation is very interesting because it shows you that each time there's a wave, the peak of that wave is higher than the previous wave. And the brutality of the wave is more intense than the previous wave. You see the similar pattern in Egypt. And again, Egypt is now again going up towards what we call the fourth wave. You can see the different peaks. And again, it suggests that we are not out of the wood yet as a continent, even though overall countries are seeing a decrease, but it takes a little or no time for this virus to come back, rebounds back fiercely. This is the situation in Mali, also going towards the fourth wave. We published these findings in the Lancet in April of this year, where we clearly showed that the continent, the severity of the second wave, at that time we were dealing with the second wave, was more severe than the first wave. And we have now documented also that the third wave, the severity of the third wave is significantly severe than the second wave. And each time we have these waves and there are lockdowns, it costs the continent about $29 billion just because of the lockdown. So it becomes extremely an untenable situation to continue to go from lockdown to lockdown and wave to wave. In this scenario, we at Africa CDC have deployed what we call the SWAP teams in multiple countries to support countries to respond to this pandemic. This is an example of what we call a SWAP team in Zambia that arrived with a consignment of respond commodities to continue to support that country to respond to some of these waves. What is the driving force behind these waves? Mainly in Africa, the Delta variant, as I will explain later, has become the predominant variant and is actually driving this epidemic in Africa. If you look carefully at this on your right-hand side, it shows how the reproductive rate of this virus has changed since it was known. Very early on, if you recall, if you look at the top left-hand panel, when the virus was first identified in Wuhan, the reproductive rate of the virus was around 2.4 to 2.6. But now, if you look at the Delta variant, the reproductive rate is around 5 to 8, which means for every 1 person infected, that individual can infect more than or close to about 8 more people. It is approaching the R0 or reproductive number of mumps or measles virus,
which are viruses that are extremely transmissible. So I think that is where what we believe is partially driving this pandemic and sustaining its evolution in Africa. In order to address this, because of the centrality of these variants, we have set up a network of laboratories across the continent that is facilitating those countries that do not have the sequencing capabilities to support countries that have sequencing capabilities and move the samples to either specialized labs or regional hubs for analysis. And about 52 countries have been supported through this initiative. And collectively, we have generated about 44,000 genomic sequencing. However, it only represents about 0.5% of the overall 8.1 million COVID-19 cases sequenced so far. However, we believe we are on the right trajectory because about 244 genomes are generated daily now on the continent. And we continue to support member states, at least 48 of them, are now reporting to us every week. Just to show you an example of how we have progressed, in January of this year, only 5,300 genomes from 27 member states in Africa were analyzed. But as we speak, as of September, 44,000 genomes from 53 member states, 53 out of the 55 member states that make up the African Union, have been analyzed. And this graph shows you the trajectory on how quickly, since January, we are beginning to generate sequences across the continent. This graph shows you the distribution of these viruses across the continent. Starting from the blue map, it shows you very early on that it was predominantly the alpha variant, and then the beta variant, and subsequently the delta variant. We also have a few countries, about 2 countries, are now reporting the gamma variants. This is a remarkable slide because it shows how the Delta variant came in around the period of April, where the blue arrow shows very clearly and took over. And as we speak, as of September this year, predominantly most infections are driven by the Delta variant, which is in red. Shows you again how these variants evolve. And if we do not vaccinate at scale and speed, we'll continue to see these variants, and which will challenge all of us. So before I go to the next chapter on diagnostics, let's see the main lessons we've learned from here. First of all, that the continent is not out of the wood yet. The 4th wave will be here soon. Continuous political leadership is very important. Vaccine delivery is extremely, extremely important for our continent. Community engagement and continuous use of public health measures and avoiding large gatherings and supporting community surveillance and ensuring that we have adequate supply of personal protective equipment remains the cornerstone for us to fight this pandemic and avoid moving from wave to wave. Let me now discuss the situation of the COVID testing. This map is extremely interesting. It shows the evolution of how Africa CDC established testing capacity on the continent from January. January of 2020, there was absolutely no laboratory and no country in Africa that had the ability to test for COVID-19. None. So if the continent had been hit around January, there would be no way for us to know how the pandemic was spreading, or the outbreak, as it was called at that time. We scrambled. And in February, to be very specific, on February 8th, we scrambled and started our first workshop in Senegal, where we brought in 16 countries. Senegal is on the extreme right, left-hand side of the map of Africa in a green color, or blue color, as you. Then 2 weeks later, we were in South Africa and brought in another set of countries. And progressively, by August, we have turned the country completely, the continent completely blue, which means all countries then had the capacity to test for COVID-19. But again, it shows the limitation of the capacity on the continent, especially for diagnostics, for manufacturing of the diagnostics, which must be factored when we discuss the new public health order that I will conclude my talk with. We were left at the mercy of chance, because at that time, I remember writing a paper as a worldview in Nature, which I said very clearly that Africa needed to be led into the market for COVID-19 diagnostics. We then established a partnership called a Partnership for African COVID-19 Testing, abbreviated PACT. And at that time in April, ladies and gentlemen, as a continent, we had conducted only about 300,000 COVID testing, 300,000 out of a continent of 1.2 billion people. Today, the situation has changed significantly, and we are about close to 80 million tests that have been conducted, which is significantly still low. As you see on this curve, it shows you what we call a cumulative positivity rate, which the red line you see in the middle tells you the test positivity rate, which is around 11%, which clearly shows that the numbers are still relatively high. That is the virus circulating on the continent. The blue lines you see there, or the blue colors, indicate the daily cases. And then the gray color or the orange color represents the daily test cases there. And you can see that the number of cases continues to decline, and the number of testing have increased over the COVID pandemic period in Africa. Africa CDC continues to support member states with providing them both with the rapid tests, antigen tests. Just over last month, we shipped out 6.2 million cases of antigen tests. Also shipped out about 6.6 million COVID PCR testing, including 2.8 million swab, that is accessory material needed to do the testing. This graph, again, as I've indicated earlier, the more we test, the more we are sequencing. So this is some of the trainings that we have been conducting just to increase our ability to support the continent to do COVID testing. Just over the last 2 months alone, we've trained over 15,000 Africans across all 55 member states using either what we call the ECHO platform, which is a Zoom platform, or in-person training to facilitate and increase the ability to do PCR testing, antigen testing, or sequencing across the continent. So there are urgent needs if we have to catch up with the testing in Africa. We need to continue to strengthen PCR testing across the continent, that is, decentralize it within the country. What we have done is to put testing in major cities, but we need to decentralize that into more remote areas. Then also increase the ability for the community to use the rapid antigen test and build the ability, expand the ability to detect variants and improve on the quality assurance, both for COVID testing and sequencing. Let me just then go to the third and last topic of my conversation, which is mainly around vaccines. As a continent of 1.2 billion people, we set up a target last year based on science that we need to vaccinate up to 60% of our population. That will require that we fully vaccinate 800 million people between this year and next year. And that will require 1.6 billion doses of vaccines. As a continent, President Ramaphosa, who was the chair of the African Union at that time, asked us to go out there and establish what we are calling the African Vaccine Acquisition Task Team, AVAT, so that effort can complement the 26% of doses that we were promised from COVAX. COVAX, as you recall, is a mechanism that was set up by the World Health Organization, the Global Vaccine Initiative in Geneva, and UNICEF to supply the world with vaccines. And 26% of Africa is expected to obtain about 26% of the vaccines. That way we can achieve our 60% target. We are eternally indebted to the Afri-Exim Bank because they facilitated us, the AVAT process, by making available $2 billion for us to contract those vaccines. So as we speak, as of today, we've signed contracts to be able to obtain 400 million doses of the Johnson & Johnson vaccines between now and next year. The distribution of vaccines from the AVAT mechanism have started. We've distributed about 6.5 million doses across 27 member states. And by the end of November, we would have distributed 35 million doses across all member states, 35 million doses by the end of November. So the continent is not just waiting for support from outside. The continent is organizing itself in an unprecedented manner under the coordination of the Africa CDC to take its own health security into its hands and make sure that the continent has vaccines. Hopefully, these efforts will complement what COVAX has promised the continent so that we can achieve our 60% immunization target by next year. This picture and the subsequent ones you see shows how some of the vaccines from Harvard are arriving the airports, different airports in Togo. That is the Minister of Health of Togo receiving the Harvard vaccines. That is Botswana, the Vice President receiving the Harvard vaccines. That is Cameroon with Africa CDC staff receiving Harvard vaccines in Cameroon. And that is Nigeria, the Minister of Health receiving the Harvard vaccines in Nigeria and Zambia as well. And I was at the airport just a few weeks ago with the Minister of Health of Ethiopia, Honorable Minister Laureate, to receive the vaccines as well. The problem we face in Africa has nothing to do with vaccine hesitancy. As you can see on this graph, both in Morocco, Rwanda, and Zambia, you see long lines of people standing outside clinics waiting for vaccines. The true problem we have in Africa is predictable access to vaccines. The video you are seeing on your left-hand side are Indian young people lined up in Morocco waiting to be vaccinated. I was in Morocco just over 4 weeks ago, and I was amazed to see these long lines of people standing outside a sports complex waiting to be vaccinated. So the real issue and challenge we have on the continent is predictable access to vaccines. So where are we as a continent? As of October 16, about 206 million doses of vaccines have been supplied on the continent. Of that, about 166 million doses have been administered, representing 80% of uptake. So again, this justifies what I just stated earlier, that it is not an issue of uptake for us, it is an issue of access to vaccines. So once vaccines are available, the uptake is good. 80% of uptake is high enough, and the other 20% is because of the distribution challenges to move it into the more distant areas. Countries like Morocco, Mauritius, and Seychelles are making good progress, but Morocco is a unique example because it is a big country, unlike Mauritius and Seychelles, whereas smaller countries. So it can be done. The reason I project Morocco here is that if vaccines are available, countries can use the vaccines up effectively. But as a continent, we are vaccinated just under 5% of our population fully. And this graph shows you where we are in the world. It shows you that as a continent, we are vaccinated only about 7.5% of our population, including the first dose and the second dose. This compares to other parts of the world. The percentage range for about 63% in the United States. Brazil is showing about 72%. China about 76%, India 49%, and other countries. So the continent of Africa is still lagging behind significantly. And again, this graph puts it in context. Africa is indicated here. If you combine both the first dose and the last dose and compare the bars with the other parts of the world, it shows that we are very, very behind to meet our 60% target. We warned of this inequality early on. Last year, we published a paper in October in Nature where we said, we described how Africa should have access to vaccines. And very importantly, we warned that history must not repeat itself as we engage in the battle for vaccines. Why did we issue this warning? Because in 1996, ladies and gentlemen, if you recall, antiretroviral therapy was available in 1996. And the graph you see here in blue is just an example of how mortality decreased significantly in the United States. But the red line, as you see, is Africa, where access to ARVs only became available around 2003, 2004, and mortality started decreasing only after 2005 in Africa. And between that period, about 12 million Africans died because of lack of access to treatment against HIV/AIDS. We should ensure that this doesn't happen again on the continent of Africa. When you look at the whole concept of vaccine nationalism, and you project back a little bit, you see that it's a regular pattern that doesn't bode well for global solidarity and cooperation. It says that when we are commonly threatened, our own internal impulses take over. In 2009, if you recall, during the flu, there was a pandemic at that time. A new flu strain was identified. And if you look at the storyline at that time, and you compare it to now, you probably think that we are in 2009. One storyline in Wall Street Journal says rich nations lock in flu vaccines as poor ones fled. The second one says most of any vaccines for new flu strains could be claimed by rich nations pre-existing contracts. That was in 2009, and today in 2021, we find ourselves in very similar scenarios. And the concept of vaccine nationalism, which was won last year, continues to be an issue, as I've explained, and we should always examine this as to why is it a recurrent effect. And I'll argue that Africa needs its own vaccine manufacturing capabilities. As a continent, we only produce, we import 99% of our vaccines and produce only 1% of the vaccines, which means 12 million doses of vaccines are manufactured in Africa. As a continent of 1.2 billion people, we consume 25% of global vaccines. So it clearly suggests to us that with the limited vaccine manufacturing capacity that we have on the continent for other vaccines, not COVID-19 vaccines, we should ramp this up quickly so that we can begin to, as part of the overall global health security apparatus, continue to position the continent in order to produce effective vaccines. It is extremely important that for our collective security, a region as big as Africa of 1.2 billion people engage in this journey. In order to address this, Africa CDC has been convening political leaders. As you can see on this picture, the head of states across Africa, President Tshisekedi, who is the chair of the African Union, President Ramaphosa as the COVID champion, President Kagame, Dr. Tedros, the chair of the African Union, and others. Last April, we convened a meeting, a summit on vaccine manufacturing, where in 2 days, 40,000 participants participated from 70 countries. We were extremely amazed to see that level of interest. At the end of that meeting, the continent launched a partnership for African vaccine manufacturing, abbreviated PAM, which is going to be a framework and a roadmap for us that will enable us to manufacture vaccines for the continent. President Kagame at that meeting said this, and I quote, "Vaccine inequity cannot be guaranteed by goodwill alone, as we have seen many examples to convince all of us. Africa needs to expand production capacity for vaccines and other essential medical products," end of quote. As I said earlier, that if the pie chart on your left-hand side shows where we are, we import 99% of our vaccines and produce only 1% locally. The strategy that we put forward as part of the PAM, that is the Partnership for Vaccine Manufacturing, suggests to us that in order to guarantee our health security in the next 20 or 25 years, we should be able to produce 60% of our vaccines locally in Africa. That is a journey that we have embarked on. It's an ambitious journey, but I must say I'm extremely delighted and encouraged that 10 countries in Africa have now engaged in that journey for vaccine manufacturing since we launched the partnership to accelerate COVID vaccine manufacturing in Africa. We are using a regional approach where we're saying that it should not be a zero-sum game where a country manufactures vaccines and others do not. So we hope that we establish regional hubs in North Africa, East, Southern, Central, and West Africa that will facilitate vaccine research and development across the continent, and use the whole of Africa approach, which means we leave no country behind, in order to really coordinate our efforts and put vaccine security at the center of our development. Ladies and gentlemen, there are some 4 lessons we have to learn: that the 4th wave will continue to present itself. Variants are a serious threat to even our vaccine coverage, except we vaccinate at speed and at scale. That we may, as a continent, still have the worst to deal with before it gets better. And vaccine manufacturing is a key security issue for the continent. As I move to my conclusion, ladies and gentlemen, let me put the COVID-19 pandemic in the right context of our challenges in Africa. As a continent, we are faced with 3 different pockets of challenges: the emerging diseases, including COVID and Ebola. As we speak, I have just dispatched a team to DRC to support the country to fight the recent Ebola outbreak, which occurred just last weekend. We have endemic diseases like HIV, TB, malaria, and non-communicable diseases, and vaccination programs. At the center of this, in what we are calling syndemics, in the middle, are areas that we need to focus on. We need strong public health institutes. We need strong public health workforce, regulatory mechanisms, the ability to manufacture vaccines, diagnostics, and therapeutics, access to financing, including, very importantly, domestic financing, and what we call respective partnerships. Each year, because of these diseases, emerging infectious diseases, 227 million years of healthy life loss are incurred on the continent because of infectious diseases. And they do cost the continent about 800 billion in productivity loss. So we have to invest in this area and reimagine our public health systems significantly. This graph shows you how diseases have emerged in Africa over the course of the last 50 years. And it suffices to say that every 10 years, there's a new disease that emerges on the continent, and the continent needs to deal with, from chikungunya virus, from Zika virus, Ebola, the Marburg virus, the monkeypox, HIV/AIDS, and now the COVID-19 pandemic. So the continent, in order to guarantee its own development and national security, and I use the word national security deliberately, we must engage in what we are calling a new public health order. We published our concept and vision of a new public health order in Cell just last year, which we clearly stated that, as you all have articulated, that there are key areas that we must invest in, including continental systems and organizations like Africa CDC. We have all seen the critical role and the centrality of a public health agency like Africa CDC, but Africa CDC cannot do it alone. We have to strengthen national public health institutes and research capabilities that will generate R&D, so that the discussion is not always about transfer of technology, but that we can co-create technology from the continent that can also be exported. We need to enhance our workforce agenda, focus on manufacturing of both diagnostics, therapeutics, and diagnostics, and work on effective partnership with the private sector to raise financing across the continent. Ladies and gentlemen, let me conclude where I started by expressing my sincere gratitude to the Boris Men Institute for according me this year's prize. As I stated earlier, I will be devoting this and dedicating this prize to supporting the vulnerable populations in the southwest and northwestern part of Cameroon, because of the ongoing crises that are there, have exposed and completely weakened health systems and facilities in that part of the Cameroon. I thank you so much again for the opportunity to honor Africa CDC through me with this prize. Thank you.
Thank you, Dr. Nkengasong. We congratulate you. You're an inspiration to all of us. And as we say here, we wish you Mazal Tov, good luck and congratulations. If you have some time, we'd like to open it up just to a few comments from viewers, participants, if that's agreeable to you, sir. Dr. Nkengasong? Would you be open to just hearing some comments or?
Yes, please, yes.
Okay, so let me open it up to the floor. If there's anyone who would like to talk, please indicate to us now, and we will allow you to make some short remarks. Professor Koresh, I understand you would like to say something?
Yeah, thank you very much. First of all, congratulations. This was a wonderful talk and amazing achievements. I think it's very impressive, your comment about how interconnected the world is, how that makes us both vulnerable and strong. And it's very impressive, your vision of increasing laboratory and scientific capability, and your vision for actually taking the crisis to emerge stronger. I wonder if you would comment for a minute or two about, have you seen, you've worked in this for a long time, getting, Israel knows about troubled regions, poor countries having to have innovation and rise above it. Africa has had its struggles. Has this crisis broken some barriers for you and made some things possible that were not possible before? Is there a light for this?
Dr. Linden, should I take that?
Yes, please.
No, wonderful, absolutely. I think this crisis, Professor Correll, we have seen an extraordinary unity of purpose across the continent, where every Tuesday, It used to be every Tuesday, but now we do it every other Tuesday. The best scientists across the continent will come together under the platform we are calling the African COVID-19 Response Task Team to discuss the way forward, share experiences, and actually support each other. The likes of Professor Muyembe, the likes of Professor Amadou Sall, and across the whole continent, from north to south, west to east, they all come together to discuss this. So I think this has been one of the best silver linings that, the continent has never had this kind of coordination and this kind of, the amount of scientists coming together to discuss this. The genomic analysis that I just shared with you is all emerged because of this pandemic, where in 2019, before this pandemic, we set up what we call the Africa CDC Pathogen Genomic Institute, which at that time, it was a theory. We said to ourselves, we should get ourselves organized and use and rely on pathogen genomics. How did we know that by the end of the year, we would be challenged? So I think we need to build on that. Second, the emergence of a whole network of countries that are now trying to manufacture vaccine is done under the coordination of Africa CDC. Every month we meet with them, we show them the ecosystem for vaccine manufacturing, and then make sure countries understand with the journey of vaccine manufacturing and build partnerships with the MasterCard Foundation that has given us $1.3 billion to support some of our activities, build partnership with the European Union that have allocated $1.2 billion to support manufacturing in Africa. So I think there's an unprecedented amount of unity of purpose that has emerged because of this pandemic in Africa.
Well, thank you. I think that's wonderful and important, as you say, for other emerging infections. And the syndemics idea you had, I'm glad you didn't leave out the non-communicable diseases and about efforts for hypertension, diabetes that we'll have to continue to fight for many years. Thank you.
Absolutely.
Thank you, Professor Koresh. Would anyone else like to make a comment or ask a question?
Yes, I would like to just reiterate our invitation to you, Dr. Nkangason. As you know, Israel has one of the most articulated institutions of public health in the world. And with your initiative and force and your optimism about the general optimism in Africa to bring everybody together, I think it is of significant help. We could be of significant help to share with you the knowledge we have accomplished. We have established our system exactly 100 years ago, and it has really worked out for us in the last epidemic. And Professor Sylvia Cotton and myself would simply love to have you with us, share this knowledge with you so that it be used by you and your team, so that Africa, so that we stop these waves of extreme epidemic in Africa using our system and your initiative and strengths. So we will work together to bring you here to Israel and expose to you everything we know so that you can use it in the African continent in the way you have done so amazingly well with the COVID-19 epidemic. Thank you so much for sharing your knowledge with us. And we do look forward for your visit with us. The sooner the better.
Thank you so much. And we reiterate what you've said, Professor Sennett, and thank you all for joining us. It's been exactly an hour. We again congratulate Dr. John Nkangason on receiving the BMI Prize, and we thank you all for joining us. Good evening and shalom from Jerusalem.
No, thank you. Thank you so much, Professor Sennett. I can't wait to come to Israel. My wife and I love Israel. It is our favorite destination. I can't wait to come there with a group of scientists from Africa. So I take your invitation up before you change your mind.
Thank you very much. Thank you all.